Okay, so we're going to discuss some other dental procedures, endodontic procedures, I mean. So firstly would then be our pulpectomy. So our pulpectomy is basically the removal of the entire infected pulpal tissue, especially in adults. We remove all pulpal tissue up until like basically 1 to 3 millimeters short of the apex. So this is normally the first stage of a root canal, because thereafter that's when, so we basically try to remove all the necrotic or inflamed tissue. Then thereafter we're going to work towards widening, enlarging, and actually shaping the canal before we place the final material in there. So it is indicated for permanent teeth with deep caries, and then from there even teeth with vertical fractures. That's when then we'll go for a pulpectomy. Then from there we have a pulpotomy. So a pulpotomy is basically where we remove the coronal portion of the pulp, so that basically essentially the pulp remains in the root canal. So you're removing only the exposed or the coronal aspect, and then you maintain or leave behind the vital intact pulp that is at the apical portion of the tooth. So pulpotomies are indicated where primary teeth with like pulpal exposures. You know how primary teeth have very wide root canal chambers. So sometimes you might be doing like a normal filling, then you get into the pulp chamber by accident. So that's a situation, for example, where you would do a pulpotomy. Or sometimes the patient has deep caries in a primary tooth, so you so much just go in with a pulpotomy just to try and save that tooth. Then from there, even pulps exposed after an accident, so the stimuli or the injury is like very recent, so we can actually attempt to save the rest of or the coronal aspect of that pulp. Then from there, in deep carious lesions like I mentioned with my example, the primary teeth, then from there where the root does not develop completely, and in anterior teeth that are fractured, so you will just address that little coronal portion without actually doing a very extensive procedure. So now here is slide 51. So they're just basically showing you how we do a pulpotomy. So a pulpotomy, basically you get in there, anesthetize, and then from there just drill the tooth and actually find your coronal aspect or the roof of your pulpal chamber. And then once you're there, you basically just remove the coronal portion of that pulp. And once we're happy that we've just removed the coronal aspect of our pulp, then you basically just use a sterile cotton pellet wetted with chromocresol solution. So yes, or sometimes in other practices in South Africa we make just use of a cotton pellet with sterile water. Just make it damp, not wet, just damp, before actually placing it into that pulp. And then from there you will then close it off with zinc oxide eugenol cement. So that's basically what that slide is explaining. And then from there we have surgical endodontics. So surgical endodontics is when we basically do surgical interventions, so that we actually try and save a tooth instead of just extracting it. So this basically involves the facial surface to be facial surface incision to expose the bone. So on the facial surface we then make an incision, normally like a half moon incision, and then from there we're going to remove that underlying alveolar bone. And then once the root has been exposed, we then vertically cut a piece of that root and actually place material or an apical curettage, sometimes like GIs, sometimes resin, sometimes amalgams. Amalgams are not really indicated because they can discolor your mucosa, but they are effective as an apical curettage. And then from there, like I mentioned, the root is exposed and then the treatment is performed. This is a very tricky treatment option, but also very effective. But if you have a good x-ray and you know in what direction you're looking for something, you should not get lost or struggled with this particular procedure. So here's an example, being your apicectomy. So basically in an apicectomy, the apex of the root and its infection, let's say if now a toothache presented with a periapical abscess, then you decided to go for an apicectomy to try and save that tooth after it was coronally endodontically treated. So then from there you remove that root, and then and the infection is then surgically removed. So that's essentially, you're going to make an incision, and then you're going to measure 2 to 3 millimeters close to the apex of the tooth. Then from there we're going to remove that aspect of our root, and then place material before we actually stitch it back to its original form. So that's basically what happens with an apicectomy. Then a root amputation is a surgical procedure to remove more of the roots of the multi-rooted tooth. So this is then found or exhibited with teeth that have extensive bone loss around the root. That's when then you will go for a root amputation in an attempt to save this particular tooth. Okay, and then with a hemisection is basically the surgical removal of a root as well as its overlying crown. Yeah. So yeah, surgical removal of one root and the overlying crown. So the diseased portion of the tooth is then basically removed. So in this section, with the hemisection, we basically remove it or divide it buccolingually just before the bifurcation of a tooth. Hemisections normally are done on molar teeth or multi-rooted teeth essentially. So the indications are similar to a root amputation in that you basically are removing a diseased portion of a crown, and especially in teeth where there's extensive bone loss around the tooth, that's when then you will then do a hemisection. We then have apexification, ladies and gentlemen. So apexification is basically the treatment of a root canal apex in a tooth that is essentially necrotic. Ne? So apexification just creates a calcified barrier across the open apex of the tooth. This treatment involves cleaning and shaping of the canal to remove debris and bacteria, which is followed by placing a material such as a drug or a paste into the canal of the apex. So we have different forms such as zinc oxide or calcium hydroxide that have been used to temporarily obturate the canal and stimulate apical calcification. So then calcium hydroxide is normally used because of its bactericidal properties and its alkaline pH. And then lastly, we have apexogenesis. So apexogenesis is the treatment of the pulp of a young tooth with an open apex. So normally the tooth in this case would be vital, but it would have carious or traumatic exposure, being reversible or irreversible pulpitis. It is then treated with a pulp capping or a pulpotomy, as we had discussed earlier on, to permit continued closure of the open apex and the growth of the root. So then calcium hydroxide is prepared again, and it is also indicated for this type of treatment. In most patients, a calcified bridge will form across the exposure, and then the pulp will heal and stay vital, and the apex will continue to develop and to mature. Then we have a little dental check that you guys can do, but that's basically it when it comes to endodontics. I hope you guys learned. If you do not understand anything, please do not hesitate to email me or just ask a question underneath in the comment section of our YouTube channel. Okay, guys? Yeah, so any questions, do not hesitate. If you don't understand something, do not hesitate. A lot of these materials and stuff will not make sense up until you've gone to the lab. So please correlate whatever you've done at the lab with what I've already said. I think the most important thing is, guys, to understand the different procedures, to know the type of questions that you have to ask a patient, especially during our examination in terms of pain, the type of pain, the type of test that we'll do to actually test that tooth. I need you guys to know the type of materials that we're going to be used and in which instances they are used and their function. And above all, guys, the post-operative instructions that you're going to give the patient after endodontic treatment. That's essentially what we expect you to know as a dental assistant. In addition to that, I can also include in private practice, you guys help with x-rays, so you need to be able to obviously practically take good x-rays and identify what actually makes a good x-ray. Okay, in terms of endodontic treatment, remember how we discussed that you need to see adjacent teeth, but more than anything, even the periapical area of the tooth that we want to treat. So that's basically it, guys. I'll just quickly check with Dr. Oosthuizen's slides if there's anything that we did not cover here, so that I can just quickly run through it before we go on to another topic of discussion. I hope you guys enjoyed. I hope you guys learned something. You better have learned something. Yes. Yeah. I'll see you guys next time. Nah. Bye. Hi again, guys. I've gone through Dr. Oosthuizen's slides now. They are also very user-friendly. Please use both the Cengage and Dr. Oosthuizen's slides just to add meat to your study material. The one thing that she covered that was not covered in the Cengage slides were radiographs in endodontics. You remember I kept telling you guys that we take at least the minimum of 5 x-rays when we do a root canal treatment. So here she discussed them, but they weren't discussed that side. So it's the five x-rays that we expect you to know. So there's the initial radiograph, so that's like the first x-ray we take when the patient actually comes into our chair, just to diagnose like pulpally and periapically what is happening with the patient, right? Then from there is our working length x-ray. So that x-ray basically determines the length of the canal, so from the coronal portion up until 2 to 3 millimeters short of the apex. So that's what we basically determine from our working length x-ray. Then from there we have our final instrumentation x-ray. So once we've cleaned all of our canals, we're going to place K files into all of the canals at the working length that we've determined, and then we're going to take an x-ray. So instead of exposing the patient, let's say we're doing our tooth 1/6 where there's like 3 canals, instead of exposing the patient 3 times, we're going to put 3 K files into those canals and then take an x-ray picture of that. Then from there there's the root canal completion x-ray. So this x-ray we take once we're happy with the working length and how deep the K files were in the previous x-ray. We're then obviously going to paper dry and then place our GP. So our root canal x-ray is basically the one that we take after the tooth has been temporized. So after we've placed the GP with the cement and we've actually closed the tooth officially, we take an x-ray of that. And then from there we then have our recall x-rays. So these are the x-rays that we take obviously once every time the patient comes back. We just routinely just check if there's no leakage, there's no seepage, if the periapical area has improved and the tissue around that tooth has improved. So those are some of the things that we'll be checking for with the recall x-rays. And then from there, she has a slide about the requirements of the film. So basically what we expect to see from an endo x-ray. So an endo x-ray must show 4 to 5 millimeters beyond the apex of the tooth and the surrounding bone or pathological condition. Like I told you guys before, if we do not see the periapical x-ray, it is considered an unacceptable x-ray for endodontic procedures. And then from there, it must present an accurate image of the tooth without elongation or foreshortening. So essentially, it mustn't, like, you have to place your film or your digital sensor in such a way that it doesn't make the tooth seem longer, because obviously then it will affect your the millimeters or the lengths that you guys would determine based on the x-ray. Then from there it must exhibit good contrast so that all pertinent structures are readily identifiable. So like we're saying, good contrast so that we can see the tooth as well as the surrounding areas. So that's basically essentially what we expect from a film. This is also very important, guys, and it's in Dr. Oosthuizen's slides and not in the Cengage one. So please just make note of that, but try and use everything that you found under endodontics and just tie it up all together. Then from there you shouldn't struggle. Another thing I see that you guys do not have are the post-op instructions. They're not in your textbooks and they're not in your slides. So I think I'll just communicate with the staff and send the endodontic post-op instructions, because that you should know that side, and then it will be distributed to everybody. Okay, so yeah, see you guys soon. Sharp.